Okay, everyone, we have kids from the back.
Thanks, Julia. Hello, everyone, again. I'll be taking on the whole talk this time. I'm not sharing it with anybody. And I'm going to try to talk about oral feeding and some of the challenges that these kids have from the critical care unit and beyond, knowing that there's a broad range of people here and different access to different team members. So I'll try to acknowledge that as I go through. I have no conflict of interest to disclose. And the objectives I have today are talk about the common feeding problems in this population. I'm going to talk about each problem sort of individually by outlining the clinical presentation and then talk about the strategies that we use. And lastly, I'll talk about how I'm going to sort of tie back to the presentation we had this morning where we talk about neurodevelopment and how that can impact feeding. So before we talk about problems with feeding, we need to address normal. How do you expect a baby to feed? And I have on the left-hand side of the screen there all the different, or right-hand side, sorry, all the different sort of pathways that, or all the ways that people feed babies through their lifespan, especially around the first year. So as a neonate, in the first sort of 10 to 14 days of life, they'll be feeding very reflexively. They'll be coordinating their suck, swallow, breathe, ideally. They'll have very inconsistent wake cycles that will impact feeding. As they're establishing feeding, they will be taking very small volumes frequently. Feedings can take a long time. And but most babies should be able to regain their birth weight unless there's other underlying issues within 10 to 14 days. That then evolves by 3 months into a very efficient feeder. Feeding should be by breast or by bottle 10 to 15 minutes. They should be able to take larger volumes and go longer stretches between feeds. And because the baby around 3 to 4 months is starting to develop more of a sleep-wake cycle, you may see an emerging feeding pattern where a baby wakes up and has a bottle, is alert for a period of time, and then has a nap, wakes up, has another bottle. So you'll see less inconsistency. By 6 months, most babies are starting solids. It's often very messy and inefficient at first, but as they gain oral motor skills, they can build the ability to eat. And as they reach a year old, the volumes of breast milk and formula will decrease because they're taking over their solid intake. By 1 year, you should be seeing self-feeding skills. Their oral motor skills should be more efficient and they should be able to take larger volumes. And they may continue breastfeeding in some situations. They may continue bottle feeding in some situations, but there should also be an introduction of some sort of open cup as the baby's straw cup drinking too. So the kids that we see have a lot of interrupted feeding. They have prolonged and sometimes multiple hospitalizations in the first year of life. Many can be tube dependent. They have many procedures and sometimes open heart surgeries. There, as we talked about this morning, there can be brain injury or neurological sequelae from these events. And you probably already are aware that different genetic diagnoses are linked with congenital heart defect, and those on their own can have their own feeding challenges. So what are some of the things that we see? What is out there in the literature? So we know that feeding and growth is one of the biggest challenges in the congenital heart population. And even babies that will start out orally feeding before surgery and establish oral feeding may require tube feeding after surgery. And it is linked that genetic syndromes, brain injury, and having single ventricle, or I would even add like more complex congenital heart anomalies, are very well correlated with the need for tube feeding in order to maintain growth and nutrition. So any of these infants, if they have they will then present with significant delays in feeding readiness. They may not show hunger cues or interest because they're feeling unwell. They may not be able to tolerate gastric feeding. And as a result of the lack of experience of oral feeding, they will have delays in oral motor skills. And all of this kind of leads to bigger problems with establishing oral feeding, either leading up to surgery or post-operative. Many of the factors that influence this once they're in hospital, so beyond just difficulty tolerating gastric feeds, let's just imagine the child's in hospital. Babies that have long duration of respiratory supports are on bypass, have had history of bypass, or other issues with foregut motility and dysphagia. All of these factors will impact the achieving of oral feeding and will potentially require tube feeding. I haven't even mentioned reflux here, which is sort of something that also coincides with a lot of our congenital heart defect babies, but we'll get into that in more detail in a sec. I like this chart that outlines all the different factors that you need to have organized and under control in order to achieve full oral feeding. And all of these will play into our kids that we see in the cardiology, but I'm going to highlight for this presentation 5 of these. GI issues, I would say, is the one that we have prolonged hospitalizations for. But we also see a lot of kids, like by definition, we have kids with cardiorespiratory issues. And so I'm going to talk about that. Sensory issues, I'll get into a little bit later, and swallowing safety will be the last thing I talk about. As you heard from my presentation around neurodevelopment this morning, I have a bit of a thing about behavioral state, and so we're going to get into that first. So in order to be able to feed, you can't be screaming, crying, hyper alert, and you can't be completely dysregulated and hypo alert. You need to be in a calm alert state. And I mean that not as a child that's crying because they have hunger cues and they will calm as soon as you give them a bottle. I'm talking about kids who are in morphine withdrawal, or they're in pain, or they're some other issue that's going on causing them to be very irritable. Perhaps they're having neuroirritability post-brain injury. Yeah, so you can see the difference between a calm alert baby being able to feed and other children. Some of the strategies for these kids has to do with the things that we talked about this morning. So having a consistent caregiver who has a good trust with that baby or child and knows their cues and can read their cues, and get the child into a calm alert state in order to get them to eat. If that child cannot achieve a calm alert state, then that would be a reason to not be orally feeding at the time. The next issue I'm going to talk about, and I'm going to talk about 2 separate issues that we see with cardiorespiratory status. One is reduced endurance and fatigue. And for this, I'm thinking of kids with a VSD who are waiting for surgery and are in a certain level of heart failure on Lasix, trying to grow and mature. So these kids potentially have increased respiratory rates or increased work of breathing, which can be very fatiguing. They may also be lethargic because they're unwell and require their heart to be fixed. And this correlates with a decrease in oral feeding. You'll see that the baby may show that they're hungry and initially start eating, but then they can't maintain their feeding. They tucker out. So initially, they'll about halfway through a feed, they'll start falling asleep. They may take really long pauses to catch their breath because they're unable to coordinate, and we'll talk about that in a second, but they're unable to keep going. So strategies you would use include changing their feeding schedule. So you could have shorter, more frequent feeding. Some babies even do well in an on-demand schedule, but as you get closer, depending on the situation, that isn't actually a safe option. Having a discussion amongst the team. Here we would talk to the dietitian about increasing calories and decreasing the volume that the child needs to take in. Using NG tube and just offering whatever the baby can comfortably take orally, but not really worrying about them having to take the full amount if they're too tired to be able to do so. And a lot of education to establish realistic expectations to the families in a gentle and kind way, because usually these kids are at home that I work with, and the families are really having a rough time trying to feed their child. It takes all their time in the world. The next thing these kids have trouble with is a coordination of suck, swallow, breathe. And it pretty much is along the same lines as the duration, the endurance and fatigue that I just talked about. But essentially, if you're breathing really fast and you're working really hard to breathe, you're going to prioritize breathing over eating. It takes about 1 second for a baby to suck, swallow, and then breathe before they can start the next cycle of suck, swallow, breathe. So if you have a child that's breathing 60 breaths per minute, they are likely going to struggle to maintain their suck, swallow, breathe coordination. And that will lead to a decrease in oral feeding. Please feel free to jump in and stop me at any time if what I'm saying makes sense. So what you'll see for babies with poor coordination of suck, swallow, breathe is they'll take inadequate breaths during a sucking burst. So they'll suck, swallow, suck, swallow, suck, swallow. Notice there's no breath taken there. They may have very short sucking bursts where they will swallow, but then they take long pauses to catch their breath. Depending on the kid, they may just start to lose a lot of milk out the front of their mouth. So they know they want to eat, but they edit the amount that actually goes down, and most of it comes out the front. Some will have very shallow respirations, and feeding actually increases, like say they're chicken neck to begin with, they'll actually increase their respiratory rate while they're eating. So they may be able to manage at rest, but if you add in the effort of feeding orally, it's too much. And those kids, you can sometimes see a gradual decrease in oxygen saturations just due to the inadequate breathing. And the kids might actually, once they figure out that they're in distress and need to breathe, they'll pull away. And they can even cough as well. What you do for this is essentially across the board, you slow down how quickly you're feeding them. There's different strategies for breastfeeding or bottle feeding. For breastfeeding, I usually recommend having a lactation consultant get involved or someone who can support them on breastfeeding. With bottle feeding, different positions, different nipples can be very helpful to try to slow down the flow. And if those two things aren't working, then providing pacing where you tip the bottle down to give the child a chance to breathe with no milk coming out can be another strategy. The next thing is the next big issue we're going to talk about is gastrointestinal issues. And I have reflux up there, but we'll talk about a few more that can be commonly seen. So without a congenital heart defect, gastrointestinal issues on their own can cause major feeding issues. So you add in the fact that our children have a heart condition, potentially, depending on the condition, may have poor gut perfusion, maybe just feeling generally unwell and nauseous. Those kids will have feeding problems. Now, 80% of kids have gastroesophageal reflux, where stomach contents is coming up into their esophagus, but we don't necessarily see those kids have feeding be affected. So as I'm sure most of you are aware, it becomes a disease when there's pain and inflammation in the esophagus and the pharynx that leads to painful discomfort in feeding. There obviously are other issues with gastroesophageal reflux involving lungs and other things. I'm not getting into that. I'm really trying to focus on oral feeding. So what I see that it decreases interest in PO feeding is that the child is uncomfortable swallowing at the back of their throat, or they've learned to associate feeding with being in discomfort. Now, although we like to talk a lot about GERD and reflux, I just want to highlight that there are other issues. So if you have a kid with poor gut motility because they have poor perfusion to their gut, that will also cause issues. Cow's milk protein intolerance is something that we also treat in our population, although it's less common than reflux. And postoperatively, some kids also struggle with constipation, and that will definitely also increase. So all of these signs and symptoms that I'm talking about, they often overlap. And behavior is often decreased PO feeding. So it's nice sometimes to have someone on your team who has expertise in assessing feeding to try to help tease out what is the issue and whether or not you can advocate to the team to treat that. Now, I'm just going to add in here that at Sick Kids, we tend to have an occupational therapist that's doing the feeding, and that's part of my role along with development and neurodevelopment. But depending on where you are in the world, you may have an SLP who's helping you, your team with feeding, or you may have a nurse. It depends on where you are and who has the expertise. But just making sure whenever I say OT, I'm referring to any feeding specialist in your team. So what does, I'm going to talk specifically, what does GERD look like in these kids? So they may or may not vomit. Some kids don't actually take in enough to vomit. They just take in enough to feel uncomfortable. They often appear hungry and feed really well for the first 20 to 30 mils, and then they will start refusing and pushing it away. And that, in my opinion, that's because of discomfort. They can have difficulty sleeping because if you lay them flat, they won't be able to, they're more likely to reflux and they'll have choking and coughing episodes. And without respecting or acknowledging these issues, it can develop into a feeding aversion. So the things that I often hear parents talk about is that the kid is arching, squirming, pulling away from the feed about halfway through. The image I have here is actually from a patient who I worked with a few years ago, tube-fed baby, obviously, and the mom emailed me after they were discharged to say she was convinced her child had cerebral palsy because she was so rigid and she was in these really unusual positions. And in doing an assessment and talking to the mom, this was only happening about halfway through the tube feed and after the tube feed. She had been orally feeding, but it stopped because she was in so much discomfort. And at other times in her day, she wasn't necessarily showing patterns. So she was screaming and crying with feet. And it's actually just showing how profound that rigidity can be in the baby when they're uncomfortable and arching back. What do we do? It obviously requires a full team, and we tend to work in a team approach here. Many of these kids, the non-medical strategies that work for kids that don't have a congenital heart defect, they will not work for these kids. They often need either medication to decrease their stomach acid, improve gastric emptying, changing the formula. For less severe, you may change the rate of how you're feeding them if it's a tube-fed baby, or give them smaller, more frequent feeds if they are bottle or breastfed. And then the next thing I'm just going to touch on is the positioning. So positioning in left side lying or prone can be very helpful for keeping the stomach contents away from the lower esophageal sphincter, and I'll show an image of that in a second. And also positioning the baby in a way where their hips are not too flexed can help prevent, give more space for the stomach to expand with filling when it has food going into it. And I know this literature I have in here is quite old, but it's because it's kind of this tried and true thing that hasn't really needed to change. And we see it over and over. And then lastly, and this will be a running theme through most of the topics that I'm talking about, this is the third one now, education to family to help them navigate the expectations of a child who has this is very important. So this is a little subtle, little schematic that shows why I recommend left side lying and prone positioning. So if you see in image A and B, you have a baby who's in right side lying or supine. And if you look at the orientation of the stomach to the lower esophageal sphincter, in those two positions, the stomach contents, because of gravity, is just being held in a place where it's more likely to reflux if the lower esophageal sphincter relaxes. If you're in the other two positions, so in C and in D, in prone or in left side lying, there's less likelihood that the stomach contents is going to reflux up because it's just positioned away from the lower esophageal sphincter. So that's why we recommend those positions, and that's why I often say to I literally before this talk emailed a parent and reminded them that they need to keep their kid in upright prone for about 20 or 30 minutes after a feed, otherwise they're likely going to reflux. The second last thing I'm going to talk about are sensory issues, and a lot of our kids have had either limited experiences with feeding or negative experiences around their mouth, being intubated, suctioned, cleaned, if they don't, their mouth cleaned while they're intubated, if they don't like it, for example, they will eventually learn that they don't realize that their mouth is for eating, and they don't realize that their mouth can be used for things that are good. And you add into that reflux or feeding intolerance, and you're likely going to see a kid that will gag. So if you think about yourself, if you've ever had gastritis or some sort of stomach flu, and you're nauseous or you don't feel well, and someone is trying to offer you food, you're gonna feel like you want to gag. So if you're not feeling hungry and someone's forcing you to eat, you're gonna likely gag. The gag reflex can also then evolve into a hypersensitive gag reflex and can be really easily elicited. And I like to differentiate gagging versus choking. Just we tend to use those. I try not to, but we do use those interchangeably sometimes. And choking, you can see sometimes with reflux, where the child will protect their airway while they're refluxing, and they look like they're choking and they can't move air through to take a breath. Where gagging would be they're actually able to breathe, but their body has a protective mechanism moving a piece of food forward. And I'm also going to add to that we also see in our population kids that are retching because of heart failure. And all of those three things I can see in one child at any given time. They're all kind of coexisting. The reflux, the hypersensitive gag reflex, and retching because they're in heart failure. So yeah, the top picture is actually my daughter who had a lot of hypersensitive gag reflexes, but obviously she had no other issues. We were able to work through it, and you'll see later pictures where she actually worked out and was completely fine. But it's because we weren't also dealing with reflux and a heart condition that caused her to retch all the time. So these kids will have difficulty transitioning to solids because they gag anytime something hits their tongue. They'll be willing to take food, but they won't actually swallow it because they gag. And that can lead to a delay in their ability to chew, and just a poor experience leading them to not want to eat. Some of these kids may have other sensory processing disorders as well, like tactile defensiveness and not wanting to have their hands dirty, but it's not in the scope of this presentation. What do you do? Again, this is about 3 months later. Same girl that was crying at the beginning of the top of the other slide. You give the child control. She has her own spoon, and is not as likely to make yourself gag if you're the one that's feeding yourself. It is very, very messy, but if you go very slow and very gradual, and edit your expectations, these kids can learn to eat. All of my kids in the cardiac population, I want them to smell and touch and feel the food first, so they can experience it on their hands before it goes into their mouth, so they know what to expect when it hits their mouth. Usually we start with purees and then soft solids, dissolvable solids, but lots of parents do different things. If you get stuck in one of those issues, having a therapist help navigate through can be helpful. Placing foods to the side of the mouth so you're not eliciting the gag reflex is also helpful. And if you have a child that just is not ready to eat because they are so averse, then using non-nutritive strategies that a therapist can help you with is good to choose. The last thing I'm going to talk about in terms of the big things that in that chart at the beginning is the swallowing impairment or dysphagia. Kids with congenital heart defects are more at risk of aspiration for some of the reasons we've already talked about, like especially with poor coordination of suck, swallow, breathe. But there are other reasons we're going to get into more detail now. I leave the definitions of dysphagia and aspiration there. I assume most of you are familiar with those. What do you see for a baby that's having dysphagia? You may long-term see respiratory infections, wheezing, impairment of lung function, poor growth and nutrition, and refusing to eat. And the two main things that are done, usually under the guidance of a team member in your program, would be helping with positioning and helping with thickening or slowing the feed down. There's a few different things it can do. Now, the signs that all of you have probably seen for aspiration are the highly suggestive signs that are black and white. For sure, this kid is not swallowing safely. And those are the ones where I'm getting the referral and the team has seen these already and it's pretty clear cut. The referrals where I'm getting where the kid just isn't feeding well and nobody knows why, I'm usually going through these suggestive of aspiration signs. So they might be coughing, but not all the time. They may have some underlying congestion postoperatively, for example, that's kind of messy to figure out if it's related to aspiration with feeds or if it's just related to their underlying congestion and secretion management. They may have decreased oxygen saturation, but again, our kids often do anyway. So is it more than normal? They may be having respiratory distress, increased work of breathing. Again, is it related to aspiration or is it related to their underlying cardiac issue? All of these things are coexisting with our kids, and I'm trying to tease out, is this something that is related to dysphagia, or is this something related to just their natural course postoperatively? The one that is the most, that requires the most intervention from my end is when there's vocal cord dysfunction after a cardiac surgery. And so this would be damage to the recurrent laryngeal nerve um, during surgery that will then limit vocal cord movement. This can be on one side or both sides. And just wanted to also highlight that the recurrent laryngeal nerve it also innervates sensation to the back of the pharynx. And so if you think about damage to that area, you can't close off your airway properly with your vocal cords. You may be able to close it off in other ways, but you can't. Your vocal cords are kind of the last resort for closing off your airway when you swallow. So if that's not working properly and you can't feel the bolus of food in the back of your throat when you're swallowing, the chance that you're going to time your swallow poorly and aspirate are pretty high. So that's why these kids have trouble protecting their airway during the swallow, and it leads to aspiration. So most of the congenital heart defect babies that have had an arch reconstruction or an arterial switch operation who have decreased vocal quality after surgery, they likely have a left vocal cord weakness. But we do have kids that have had right vocal cord paresis or paralysis, and those often occur after ECMO cannulation. And you can have a combination of both of these situations, um, or you could have vocal cord injury from intubation. And I'm sure we've all seen this before. So usually what happens post-extubation is you hear changes in the vocal quality. So there might be quiet, weak, hoarse, raspy. And if that is changing hour to hour, day to day, your hope is that it's not actually the recurrent laryngeal nerve that was impacted. It actually was really just an extubation related trauma in that area. While they're feeding, you may see changes in respiration with stridor, particularly inspiratory stridor. You may see those subtle or highly suggestive or suggestive signs of aspiration when they're orally feeding. These kids can silently aspirate though, which can make it very challenging to figure out what it is. Strategies. Here we would get an ENT consult. I find them incredibly helpful. Their scope really helps us identify what is going on. Then obviously you need, if there isn't already, you need the OT or feeding therapist on your team to provide support. And when you get a referral for these kids, when you're placing a referral, it's not just for the inpatient period. This is a complication from surgery in most cases, and they need to figure out what the safe feeding method is before you go home. But these kids are followed. You may not realize that some of these kids I'm following for months, if not years, getting them back to oral feeding thin liquids. So it's the beginning of a long relationship in some cases for me. You do generally need to thicken. Typically, this is a thin puree. We call it thin puree or honey consistency. Now the term is the ITSE levels. I'm not going to go into that now, but it's a C level 2 is usually what works for a vocal cord paralysis to be able to safely feed. Now I'll get into the video fluoroscopic feeding study or modified barium study next, but we always test whether they're feeding well with the consistency we think that works. So first we would we would do a clinical bedside assessment to assess bottle feeding with the thin puree, and then book a follow-up feeding study just to confirm that's considered the gold standard to show for sure that is a safe feeding method. And I ask families to get back in touch with me once their child's vocal quality has improved. It usually happens within 3, maybe 6 months, but it doesn't happen for everyone. The video fluoroscopic feeding study is, again, after you've completed the clinical assessment and figured out the plan of what you think is safe, then you go in to do the fluoro study. At SickKids, we call it a GI feeding study, but other areas call it different things. And the goal is to assess swallowing function and determine safe feeding method. The goal is not for me to identify aspiration. We may see aspiration, and this might just be like a subtle semantics that we're talking about here, but really the purpose for me doing this is I'm not radiating a kid to see if they aspirate. We're going to provide this procedure so that we can figure out how they can get home orally feeding safely. I think I've gone through most of this. There is limits to this study though. You only are going to see the oral cavity, the pharynx, the larynx, and the upper esophageal sphincter, maybe a little bit of the esophagus. You're not going to see the mid to lower esophagus, and it really is not an assessment of GERD or esophageal motility. Those are different procedures. So really, if I have families that want a swallowing study because their kid is having trouble coughing after feeds, this is not looking at reflux. It's looking at things from above going down, not things coming up from the bottom. The main disadvantage is the radiation exposure, and that's part of the reason why we have a good clinical assessment and a plan going into doing this study, because we understand that it's a lot of radiation. It's on our machines, it's 15 to 20 frames per second, so it's not just one X-ray, it's that many per second. We have a max limit of 3 minutes, and the radiologists pan in quite closely, as close as they can, to limit the exposure to the child. And the other thing to be aware of is that it's only one moment in time. So what we see in one feeding study might not reflect back to the clinical assessment, and you really need a therapist to be supporting you in a team approach for some of these kids to make sure you're doing the safest thing possible. Now I'm going to get into a couple extras. And the first one is about tube feeding. So we put a lot of tubes. Literature is pretty standard, like you will decrease the length of stay by using NG tubes. You will help, tube feeding can even help kids grow and get to surgery, but also can help them post-operatively while they're recovering. So tube feeding is used so commonly in our population. But whenever you put in a tube, we need to also think about how we get it out. Tube feeding can lead to decreased hunger cues because you're fed into your stomach without trying. And it then can perpetuate a cycle of not being interested in eating orally because you're not hungry, which then prompts tube feeding. So even after these kids go home, it's really important to know and have a plan for how this is going to get out. And if you don't anticipate for various reasons, maybe there's a genetic diagnosis or there's a long-standing swallowing safety issue that's likely going to happen, maybe post-brain injury, then you need to have a plan of what you're going to do long-term for those tubes. Now, tube feeding in and of itself has an impact on oral feeding skills. These kids are not necessarily participating in a mealtime routine in the same way. They're not getting the same variety of foods, exposed to these foods, and that can lead to increased hypersensitivity around the mouth, not wanting their hands to get messy because they just haven't experienced it. Um, I have families often telling me they spend all their day trying to get their kid to tolerate food, even if it's by tube. And so they're constantly holding them or positioning them in a way where they're running the tube so slow so that they spend all their day feeding and don't have time to do other things. Children often are not associating hunger cues with eating. They're associating hunger cues with their tummy feeling full or warm or different. So they don't understand that their mouth can be for eating. And but yeah, it just impacts feeding and learning to eat in some cases. It can be very helpful for short term, but if it becomes a long term thing, you really need to start treating tube feedings like a regular meal time. It's not a medical procedure that you're doing to this child. And I'm talking about this is beyond. This is at home when the kid's recovered from surgery and you're still dealing with tube feeds. I encourage families to bring their child to the table. If they're an older baby or a child that could be sitting up for meal times or in a high chair, include them in that mealtime with the family. They're still learning about the sights, the smells, the textures of what the food is, even if they're not putting it in their mouth. You can hold younger babies during feeding and give them a soother to help them associate feeling full with using their mouth. And this one is number 3 strategy is at home likely. You can adjust the feeding schedule to align with the child's hunger cues. Some of our families do that. And last, like some of these kids, it's just they're not ready. Medically, they may not be ready. Um, Developmentally, they might not be ready to start solids, even though it's 6 months and that family is ready to start solids. Maybe have had a significant prolonged developmental course, and it's not the right time. On the other end, sometimes they're not ready for bottle feeding, but they're 4 months old, and maybe we'll start a little bit of spoon feeding early just to see if a different experience will help that child. Um, we also have just very complex, some of our really complex kids who are admitted to the ICU. Um, no experience, that last sentence I have there, no experience is better than a negative experience. You want to wait if the kid doesn't want to eat or is not safe. This is just a little reminder that these kids, if they're feeling unsafe, like say they're breathing really, really quickly at 80 to 100, they won't feel safe to breathe and eat at the same time. They won't eat if they're in pain or feel unwell. Um, Initially, being distracted, pressured, coaxed, coerced, tricked, those things can work in the short term, but they're not going to work to feed a child long term. Being force fed is not going to work long term. If you have the entire team or family watching you while you eat, that can be a little bit intimidating. That often doesn't work. Praising a child for eating more than is really required. So, feeding should be an innate activity that we all want to do. You shouldn't have to be praised for it. So, that can build some unusual behaviors as the child gets older. And then, obviously, if they're not hungry, they won't eat well. Last thing I said I would talk about is that feeding and motor development are connected. This is just very quick. We know these kids are at risk of developmental delay. And if you have a kid that has delayed motor milestones, they're likely going to also have corresponding poor oral motor skills as well. And so you really need to match the kids' oral motor skills with their feeding skills. I've recently, not in the heart population, but I recently had a kid who was 2.5 and had a delay that wasn't otherwise understood why was being investigated. And he was operating at maybe an 8 to 9 month old level, and people were trying to feed him a regular diet. And he was not able to manage that because his oral motor skills were at the same level as his developmental skills. He was able to manage purees and some dissolvable solids, and that's about it. If you gave him anything more complex to eat, he couldn't chew. He couldn't. He would actually. He did choke and require back blows at times. So we've, just making sure that you do, or at least I always incorporate a developmental screen. It might not be a full-blown developmental assessment, but I need to know where this child's at developmentally. And because most of our kids in the congenital heart population that I'm working with are at risk of delay, that's a big part of my oral feeding. So in conclusion, these kids are at higher risk for feeding difficulties. We know that. If there's concerns, you need a team approach, and having a feeding therapist is very helpful. Having a dietitian that works closely with that feeding therapist and having a physician can be really helpful to work together, not only in the inpatient setting, but also as they leave the hospital. The earlier that assessment and treatment can happen, and sometimes I'm not actually treating these kids, I'm really just providing education and information to families to manage their expectations of what this child is ready for right now. That can have a better outcome because it can set the parents up for success and help them know how to grade this child's as they move forward. And then making sure that this assessment is provided. I already said this, sorry, but this is that these opportunities to provide assessment and treatment is available not only in hospital but in the community. So whether it's through, here I'm maybe perhaps following kids through clinic, or I'm referring out to the community supports that already exist, these kids are going to. Okay. Are there any questions with that? Yeah, I'll bring up the chat for it because I'm in my, here we go. Celia, it's giving me some weird. Please move this window away. Yeah. Sorry, guys. Got this going. Okay.
All right. We have a
Yes, I think it's lunchtime in my part of the house. I don't know about anybody.
All right. Thank you, everyone. So we'll see you back. I think it's 1:45 in Canada time. And thank you, Kate, for presenting a lot this morning. Particularly this last one as well, which was on sort of challenges and strategies of feeding children with cardiac congenital heart disease. So thank you.
Bye.